variations in the anterior cerebral and middle cerebral artery anatomy. And you're familiar with this grid now after Surendra showed it to you. So Pierre had this ability to visualize things like this, and he drew these grids. So you've seen it for the posterior circulation. This is the grid that you can draw out for the anterior circulation. So basically you start with a midline line for the anterior cerebral, one line on each side, two smaller lines on each side, and then two horizontal lines over here. And we can grid out all the possibilities of anterior circulation on this. And there's three areas of variation that we're going to cover. But let's just start with this, because these are all the descriptions that everybody learns at medical school of vessels, or when you're doing your training, right? For the anterior cerebral, we can see A1, M1. The M1 extends to the lemur insula, and then where the vessel turns up on the insula, it's going to be M2. M3 is the branches exit out onto the Sylvian fissure, and we can sometimes on a contralateral side where it's easier to see the Hübner artery giving stride supply. And then on a lateral view, we do something similar, except from M3, we can now see the distal branches on the surface. Those would be M4. And on the anterior cerebral, we can see the A2 going out onto A3, which is the callosal branch, A4, pericallosal, and A5 as we get out onto the surface of the brain. So the problem is these are not anatomically very useful, and they don't give us any understanding of the variations that we can see. So you'll know from Carl's lecture this morning that the carotid artery, which is the main radicular artery to supply to the brain, divides into a caudal division. That's going to be the PCOM and the P1, and a cranial division, which in the very early embryo, at the time of the vesicles, is the cranial division is really the proximal anterior cerebral artery. So before there's a significant MCA. And at this time, the anterior cerebral is on the outside of the vesicle, and it's supplying choroid plexus on the outside of the vesicle. So the anterior cerebral development and growth is driven by that supply to the choroid plexus. So there's three possibilities for variation on the grid, as I said. So we've got all these ophthalmic ACA variations possible because of the ventral ophthalmic artery, and we've seen most of those, so I'm not going to go over them, right? But just to remind you, the possibilities, the infraoptic A1, Carl showed you some nice examples, the duplicated A1, which is the persistence of the ventral ophthalmic, and the real A1, and the ACA origin of the ophthalmic artery. So let's move to the proper anterior cerebral stuff, the midline fusion one. So these are all the variations that take place at the level of the ACOM. And Philippe told you it's a relatively recent addition to anatomy that we have an ACOM artery. And because of that, there's variations that can occur. So the first one is, gets different names, right? Azygous anterior cerebral artery, or fused anterior cerebral artery, which is the same as calling it unpaired. I think in the books, Pierre calls it unpaired. And it can be complete. You can have whole anterior cerebral fused. That's, I think, exceptionally rare, except in opossums. But in humans, we see partial fusion of the anterior cerebral, and then the vessel usually divides a little bit further up. So this is what it typically looks like, and you'll know it's quite often associated with aneurysms. This is an example of that. So we've got a patient with a single A2 vessel up to the point of the aneurysm. At the aneurysm, the vessel bifurcates to supply both hemispheres. So if we drew that on a grid, it would look exactly like this. Single vessel in the midline up to this point, and then bihemispheric supply afterwards. Or we can have the typical bihemispheric supply. So we can have variations on this, right? It could be balanced or unbalanced. So we can have the grid where on one side we've got a very dominant vessel that's pericallosal and callosal marginal and is supplying both hemispheres further up. And on the other side, a really hyperplastic vessel that's just supplying one area. So this would be an example of that. So Philippe has told you that even in the patients where you don't see angiographically an A1, there's always an A1. When you do a preparation and dissection, there's always an A1, even if it's really insignificantly small for us to see. So that's bihemispheric supply. And because this supply can be unbalanced, we can also have unbalanced supply at the level of the A1. So if the A1 is supplying a small territory in the A2, then it's going to be small as well. And then we've got this possibility, which is the triplicated supply. This is the confusing one, right? So we can have an artery, which is a cortical artery mostly, originating from the ACOM. And again, this is an example with an aneurysm, but you can see there's too many vessels here. And when we do the injection and oblique it slightly, it's a triplicated vessel. So there's a midline pericallosal that's got cortical supply, and there's two pericallosal arteries. So it would look something like this on the grid. This is not uncommon, and as I said, the ACOM is a relatively new addition to anatomy, so because of that, it can look really complicated. You can have a duplicated ACOM, you can have multiple channels of ACOM, and this is an example of that with a triplicated vessel. So this midline vessel is a little bit confusing when it comes to its variations, and I've tried to list them here. So this is actually an article from Timo, where this drawing comes from. So this is the subcallosal artery. That's where you have a small artery that's really just supplying up to the genu of the corpus callosum. And it can have a really important perforator supply. It can supply the fornix, and it can supply the anterior commissure. So this paper was actually describing stroke in a small group of patients who had closed the subcallosal artery, and all of them had memory impairment because of fornicial infarction. So this is the subcallosal artery, which only supplies this small territory. The next one is this median callosal artery. So we have an artery that originates from the corpus callosum. You can see it here. But it's only supplying the corpus callosum. It doesn't have other cortical territory. And again, there's papers describing stroke related to closure of the median callosal artery, where the entire corpus callosum is infarcted because it's the only supply to the corpus callosum. And then the third possibility is this one, the pericallosal artery, that not only supplies the corpus callosum, but also supplies cortical territory as well. And there's even variations on this, in that you can have this vessel in the sulcal space, and you can have a small vessel that's supplying the corpus callosum by itself. All right, so those are the variations that take place at the level of the midline. But what about if we move down to the middle cerebral artery? And the possibilities that are present here is differences in cortical perforator balance, and we need to look at the perforator territories. So it's good to revise the difference between amphibian circulation and primate circulation. So the amphibian circulation, you'll see that the middle cerebral artery arises from the striate vessels. So the striate vessels supply to deep gray matter are present before we have a lot of cortical hemispherical matter. So they're an earlier addition. As cortical territory gets added on in primates, we need a bigger artery to supply a bigger territory of cortex. And the middle cerebral artery develops from striate vessels. So all that's happened in the human is we take a scissors, we cut here, and then we're left with medial striate perforators that are derived from the A1, lateral striate perforators that are derived from the MCA, but ultimately are older vessels and were there before this big cortical territory. Pierre described two different kinds of perforated territories around us. So we've got central deep perforators that are supplying the optic chiasm and hypothalamic area, so these are diencephalic perforators. And then we've got telencephalic perforators, the medial and the lateral striates that are supplying the basal ganglia. So if we look at the perforators, this is a diencephalic structure, right? The chiasm and the optic nerve. So we've got these very small little perforators that are present on these vessels that are coming off the A1 and A2 junction, supplying that area. In addition, this is an ACOM aneurysm. There's the left optic nerve, here's the right optic nerve. Coming off posteriorly at the back here are perforators to the hypothalamus. And it's not uncommon after ACOM surgery, we put clips on, can't see behind here, we end up closing those perforators and the patients end up with hypothalamic disturbance, usually fluid imbalance, because it's very difficult to see those perforators. So this is how you end up injuring those vessels, is we have to use fenestrated clips to preserve the right A2. There's the aneurysm. We've got to put this fenestrated clip over. And you can imagine there's little perforators coming off at the A1, A2 junction, not only here, but on the opposite side that we can't see because there's an aneurysm in the way. And once you've got the clip placed on the aneurysm, you can't manipulate the ACOM complex to actually see if the perforators are in there or not. And when we catch those perforators, that's how patients end up with hypothalamic disturbance. All right, so those are the deep central perforators of the A1, A2 junction. What about the striate perforators? So we know there's medial and lateral striates. And there's quite a bit of variation that takes place here. There's always some degree of balance. So there's medial and striates that are always present, but they can come off in different areas. So it can look something like this. Here's a M1, A1, Hubner vessel, but this Hubner vessel is carrying all the medial striates and the lateral striates. There's virtually none coming off the actual M1 vessel. All of them are coming off the Hubner. Or we can have this arrangement, which is the classical arrangement. So we've got medial striates coming off the A1 and lateral striates coming off the M1. Or we can have this kind of arrangement, where we've got all the lateral striates coming off quite distally, and this is still probably M1, it's just at the turn of the Lehman insula where the vessel goes onto the insular surface. But this is a very lateral group of perforator origin. And if we look at it on the grid, we can draw out all the possibilities. So we've got the main MCA line over here, we've got the line above, and we've got the little vertical lines that represent the perforators. So these would be medial striates, Hubner, and medial striate origin here. And these would be lateral striates that can either come off as a single branch into multiple candelabra type arrangement, or can be individual vessels. Not only that, but we can have anastomoses that take place between these perforators that account for some of the variations that we see. This would be one of them. So in this example here, you can see there seems to be a duplication of the middle cerebral artery, but it's not. This is really more likely a perforator anastomosis that's become enlarged because of increased flow during an embryonic period, and it's persisted. It's just remained there. This is not an uncommon thing to see. Sometimes it's more subtle. So this is a 3D angiogram, and you can see there's a medial stride coming off the A1 over here, and there's a lateral stride coming off over here, and at this point there's a fusion between the two. So there's good collateral circulation sometimes between these perforating vessels. So those are the typical perforated territories and the variations within the perforated territories. But what about the variations of striate vessels and cortical supply? So just like we can have a shift of cortical territory between the PCA and the anterocoroidal, we can get cortical shift to the perforators. So what if this upper line becomes much bigger and we have more flow along here? All the perforators come off this vessel over here. That would be an arrangement like this. So we've got A1, M1, and a very large laterally coming off Hubner with all the perforator vessels, medial and lateral striate, coming off that Hubner branch that also has a cortical territory. So this would be called an accessory middle cerebral artery. So what it really is a very big Hubner artery that's taken on a much larger cortical supply. Here's another example of a Hubner artery that's got a cortical supply. It can be really small. So we've got an example here, again a lateral origin, so there's some medial striates coming off here. Here's a lateral origin Hubner, small cortical territory, and all the lateral striates coming off. There's the vessel over here, and you can see, maybe if I zoom up on it, you can see here's its cortical territory that's continuing out here. So it's an accessory middle cerebral artery. But this is also possible, right? The real middle cerebral can have a small cortical territory, and our accessory middle cerebral, the Hubner, can have a very large cortical territory. Here's an example. So really small MCA, very large Hubner, accessory MCA, with all the striates coming off this superior branch. That aneurysm was clipped. So it's not uncommon to see an aneurysm at the vessel between these two arteries. And here's an example, again a small MCA, large accessory MCA. And the important thing to know is that all the striate vessels come off this accessory vessel. Really tiny little branch over here, much larger accessory MCA. It can be a little bit confusing separating these from proximal temporal branches. So the thing here is we want the upper division of the accessory MCA to come off the A1. Not like this, where we have a proximal temporal branch coming off the MCA. So this would be the separation of A1 into M1 with the temporal branch coming off. Another example of a proximal temporal branch rather than than an accessory MCA. If we look at the cortical territories of vessels, these are highly variable. So these are just different examples of accessory MCA vessels, some small and some large. Trying to separate cortical territories out was done by Salomon in trying to draw out sulcal markings on angiograms to imagine where they are, and then superimpose vessels on top of that. So for the ACA, what we could do is certainly on an angiogram, we could draw out where the corpus callosum is, because it's going to be just underneath the pericallosal vessel. We could then add these sulcal lines to give us the branches that we're most likely to find. So this would be orbitofrontal, frontopolar, anterior frontal branches, middle frontal, posterior frontal, parietal lobule, superior parietal and posterior parietal branches of the anterior cerebral artery. And we can do the same for the MCA. So if this is an angiogram picture, we can superimpose on the markings of the brain. So this triangle would represent the insula, this line across the triangle would represent the Sylvian fissure, and then we could start to draw in the other central sulcus and name the branches. So we've got orbitofrontal again, frontopolar, precentral, central, anterior parietal, posterior parietal, the angular branch coming up here, temporo-occipital, posterior temporal, middle temporal, anterior temporal, and temporopolar branches of the MCA. Why is it necessary to do this? It's sometimes useful, particularly if we're trying to find peripheral aneurysms. So this is a patient with infective endocarditis. There's a peripheral aneurysm that's bled. We need to find it. It's very useful to imagine these sulcal markings on here and to know that this is a posterior parietal branch in the upper division of the MCA. So when we're trying to access it, we know we need to be in one of the upper branches and where we need to be. And that helps us get a microcatheter into the right place. There's always balance between ACA, MCA, and PCA in the territories. These vary slightly. You'll know from stroke cases that there's, of course, shift in cortical territories, so there can be peel anastomoses between these territories that allow for collateral flow. But even in normal patients, there's different territories that are supplied. The ACA doesn't supply a fixed area in all patients. It can be quite a small territory or it can be a large territory, but there's always going to be balance. If the ACA has a small territory, the MCA will have a larger territory. And finally, there's other variations that can't be explained easily by embryology, but these sort of things where we have an early division of the MCA in the M1 region. So M1 would still be from here to here, but we've got an early division into multiple branches. Same on this side. Some of these can be very proximal, so we can have a separation of branches really early associated with an aneurysm. Or we can have a really long M1 segment that stretches right out to this point over here. And then finally, we've got these probably more acquired differences in MCA anatomy. So we can have dolicho-ectatic segments. This may be related to atherosclerosis, or it might be embryological, where the vessel is just is improperly formed. Or these kind of looping vessels that are probably related to perforator striate anastomoses with disappearance of part of the M1, and this just represents a collateral channel through perforators that's now formed into a large vessel. Thank you. Any questions?